The information shared on this podcast is for educational purposes only and should not be considered medical advice. Please consult a qualified healthcare professional regarding your individual health needs. You already know I don't believe in shortcuts. If you're not lifting, walking, eating enough protein, managing stress, and prioritizing sleep, peptides are not the answer. Lifestyle is the foundation, always. But here's the truth. Midlife biology can be stubborn. Hormones shift, recovery slows, body composition changes, and energy dips even when you're doing the work. That's where medically supported peptide therapy can be layered in, not as a replacement for discipline, but as strategic support. Physician prescribed, clinically guided, compounded through an FDA-regulated pharmacy. This is about optimization, not escape. If you've built the foundation and feel like you've hit a wall, this might be the next intelligent step. Lifestyle first, strength mandatory, support biology when it needs backup. If this resonates, send me a message and let's have a real discussion, or check out the link in the show notes. Health, wellness, fitness, and everything in between. We're removing the taboo from what really matters in midlife. I'm your host, Michelle Folan, and this is Asking for a Friend. Have you ever walked out of a doctor's office with labs labeled normal, but you know you don't feel normal? You're exhausted, your weight has shifted, your digestion is off, maybe your heart races, but the answer you get is everything looks fine. For too long, women in midlife have been told they're okay when they don't feel okay. Symptoms get brushed off as stress, aging, or anxiety, and we start questioning ourselves. Today, we're talking about the space between normal and optimal. What do lab reference ranges actually mean? What cardiovascular markers should we be paying attention to beyond a basic lipid panel? When is hormone therapy appropriate? And what about starting estrogen later in life? And how do we advocate for ourselves so our symptoms aren't dismissed? Joining me is Dr. Aaron Hartman, an integrative and functional medicine physician and the author of Uncurable, From Hopeless Diagnosis to Defying All Odds. His work focuses on identifying root causes, optimizing physiology, and helping patients move beyond "you're fine" to truly thriving. Dr. Aaron Hartman, welcome to Asking for a Friend.
It's great to be here. I've heard about you for a long time, so I'm excited to have a conversation with you today.
So I won't divulge who it is, but a family member of mine, actually 2 family members of mine, are patients of Dr. Hartman. And I feel like I know Dr. Hartman. And so this is fun because I've heard so many wonderful things about you over the years. And this conversation, I feel like, is way overdue. You are traditionally trained and board certified. I want to start at the beginning because what happened to your daughter Anna's health journey that led you to explore functional and integrative medicine?
So to fill out what you said, I'm triple board certified. I've had a clinical research company for years, part of 70 clinical trials. I've published in Lancet. I've been an assistant clinical professor of medicine at the Medical College of Virginia since 2010. So very academic, very typical, very nothing outside the range of normal there, right? But my daughter changed everything. And that part of the story goes back to 2006, 2007. My wife, who is an occupational therapist who works with kids with special needs, one of her patients' homes was closing down, and she said, "Hey, would you consider bringing Anna into our home to foster her?" I'm like, "Sure." And after a while, I fell in love with her, and we considered kind of adopting her. And one of the issues was her weight. She's failure to thrive, which means she's less than 5th percentile. So she was born itty-bitty, still itty-bitty even to this day, and petite. We say petite now. But and the treatment for that typically for kids is you put a feeding tube into them and put formula into that to put meat on their bones. And so when we spent months and months feeding her, went back to the GI doctor, and they said, "Yep, failure, wrong. Standard of care for all these kids. This is what we do for everybody. We're going to treat you like everybody else. Nothing special about you. You get what everybody else gets. You get a surgery. You get a feeding tube, and we get to pour sugar water with seed oils and high fructose corn syrup." And there's actually a big debate now on a government level about changing formula because it's so bad for babies. And we said no. That affects speech development. That affects brain development. It's kind of hard to learn how to walk and crawl when you have a tube out of your belly.
Mm-hmm.
The system had set the bar so low. She was never supposed to walk. She was never supposed to talk. She was never supposed to crawl. So they didn't worry about what she looked like 5 years from now. They just wanted her to look better on the growth chart. We said no to that and got reported to Child Protective Services for child neglect, for medical neglect. Yeah, for refusing to, basically, we just wanted to give her real food, so we got reported to the authorities. And so that was my first inflection point where this whole system that I've been a part of, graduated summa cum laude with a biology major from, university, all that kind of stuff. They don't like it.
Apparently.
When you push back, right? And so 6 months later, my wife, researching things, found a growth chart with kids with my daughter's diagnosis. Her official diagnosis is cerebral palsy, and she was 50th percentile. She was in the middle. So all of a sudden, it's the experts don't know. They had no idea that she was fine, that what we were doing was okay. She has this diagnosis, cerebral palsy. She's just going to be small for whatever. And in her world, one surgery begets another surgery. So to put things in perspective, fast forward 20 years right now, she's 20 years old and actually getting ready to move out of our house two months from now, which is starting to worry me a little bit. So I'm getting a little anxious about it.
Congrats, Dad.
Yeah. But she's had 0 surgeries in her life. To put things in perspective, a typical kid with her diagnosis has had 13 surgeries by the time they're her age. So literally, we've got these crazy outcomes from her by literally not doing what the experts say. I still went to the specialist, still got their advice, but always were cutting your eyes to help with the eye muscles, cutting your spinal cord to help with tone, cutting your heel cords. These are surgeries that have been recommended to her. None of them sounded good. And we've actually figured out ways around that to the point that she has beaten every odd. And that's what the book is about. And that's kind of what got me down this pathway of looking at things differently, because not because I wanted to, I had no choice. I had to figure out a different way for my daughter.
Yeah. And then that inspiration, now you are doing the same for patients. You have to just be on top of everything because things are changing so quickly right now.
Things have always changed quickly. But yeah, you do. I'm always learning something new. I was at a conference over Christmas time, the biggest in the world for integrative medicine, 9,000 people, 9,000 practitioners from around the world in Vegas, right? And I learned about a therapy called neural therapy that blew my mind. We started using it in my clinic a couple months ago after learning about it. The coin was termed in 1925. So this cutting edge therapy that 5,000 practitioners do in Germany that I've never heard of here in the United States until, this past Christmas time, is 100 years old. And there's so much stuff that's like that. Lipid therapy that I do, that's almost 50 years old. There's so many things that actually really smart mast cell activation. Lyme is now all the rage, right? Lyme disease, it's been around for decades. It's not new, right? It's just now coming to public consciousness. And there's more that's like that. People want the new flashy thing. I don't want the new flashy thing that's going to be no good in a year. I want the thing that's survived the test of time, that's around for decades that no one's talking about. And there's so much of that out there that I'm still learning. Every couple of months, I find something new I've never heard of before. And I've been doing this for 25 years. And I'm still hearing of things I've never heard of before. So
yeah, it's exciting. Was this that longevity conference that was out in Vegas?
Yeah, it's A4M Longevity. It's the biggest of its kind in the world. The top people from around the country come and talk at it, and they have all these breakout sessions. And usually what I do is I actually bought all the recordings. And it's about 200 sessions. And so over the next couple of months, I'll just listen to the talks because you can't listen to all of them there. It's just 3 days. So
yeah. Yeah, you're not superhuman. So in practical terms, how do you describe what functional medicine is to my listeners?
Functional medicine it's the ultimate personalized precision care. It's learning about you, Michelle, your issues, your history, where you grew up, your family, what you ate when you were a kid, were you breastfed, what makes you now. And then based on your lab testing, your symptoms, putting an individualized plan together for you that's unique and works only for you. It's not saying you've got diabetes and we'll treat you the exact same way I treat the last 100 people. You're depressed. Is your depression from a concussion 20 years ago? Is your depression from a folic acid deficiency? Is it from your gut, where 75% of your neurotransmitters are made? Why do you have this syndrome we call depression? Actually figuring that out and treating the person as if they're a real person, an individual that has unique needs and requirements. Like that's basically all I do.
All right. And for my audience, which is roughly 50, 55 plus women, why do so many of the women I speak to on a daily basis constantly hear your labs are normal when clearly they don't feel well?
When you look at labs, you're looking at data points. It's like those games. Everybody plays games like you put a little thing here or a thing here, and it's the mountains, or we try to guess what you're looking at. So literally, you're taking the entirety of you, taking 10, 20, 30, 40 data points, maybe 50 if you're lucky. If the person's advanced, right? And you're trying to guess without your history, and taking those data points by themselves, and not actually applying them to your fibro, your chronic fatigue, your hot sweats, your brain fog, your hormone issues, or whatever it is, to connect them. They're treating just the labs. And, if you're doing that, of course, most labs are going to come, no matter what you do, most lab results come back normal. So if I do less of them, the odds are proportion-wise that they'll be normal. Put things in perspective, when I see my intake patient gets about 500 labs done, like data point labs done. And over the period of a year, it's about 900 to 1,000. I just did a re-round on my daughter because she's going to move out of the house and I have to tune her up before she goes out. And I got 900. I haven't looked at yet. Yesterday, I got in the mail from the lab company 900 biomarkers that I have to review and put a plan together for her when she's leaving in 2 months. Like, she's got a lot of stuff going on. And that made me a little anxious because, oh my gosh, and we always have stuff going on, right? But if you're not looking at that much stuff, it's not surprising that you don't see anything, right?
Yeah. And so there's normal and then there's optimal. And I think
there's that as well. I'm talking about just in general. Then there's normal and optimal. And that's a totally different world.
Yeah. And so when a woman presents with, I'm just going to throw this out there, like fatigue, brain fog, gut issues, poor sleep, but standard labs look normal, what would be the most common blind spots for that patient?
Well, one, you can have leaky gut or increased gastrointestinal permeability, which is the thing where your gut breaks down a little bit and you actually react with the food you eat. And you can develop these things called IgG food responses. So you actually start reacting with the food you eat. And you can get that just from eating the same thing over and over again. You can also get this thing called dysbiosis, which is overgrowth of bad bacteria in your gut. 75% of all your neurotransmitters, 90% of serotonin, which is your happy neurotransmitter, 50% of dopamine, which is your go-get-em neurotransmitter, are made in your gut. So all of a sudden, if you're not making those optimally because of abnormal proportions of bacteria in your GI tract, you're not going to feel optimal. Also, 90% of your immune system is in your GI tract. If you have a brain issue, brain fog, fatigue, here's an interesting data point for you. If you get concussion, everybody who gets a concussion will actually develop leaky gut. That's how closely connected your gut and your brain is. When runners get runner's diarrhea, you run really long, that's actually a stress-induced leaky gut that causes this diarrhea. Now, the healthy person goes away. So all of a sudden, for a female, you got to look at the gut. And then your hormones is the other thing. How many doctors are checking FSH, LH, estrogen, estradiol, estrone, progesterone, DHEA, pregnenolone, which is your primary hormone of memory. No one checks that, right? And then your hormones are detoxified through your liver into your gut. So all of a sudden, there's a connection between your hormones and your gut, right? And then as far as like the brain fog stuff, the average female puts 200 chemicals on her body every day. And a lot of these chemicals are neuroendocrine disruptors, which is a fancy way of saying the chemicals act like estrogen. Phthalates, for example, are an estrogen modulator. That's the stuff that makes all your skin cream silky smooth. Yeah. That's the stuff that makes plastic like really malleable. Women put that on their bodies every day. And so you do that for decades. And there's just a few of the things I see routinely that aren't being looked at by our healthcare system that can make a middle-aged 50 or 60-year-old female feel like you can age quicker. And then there's all the nutritional stuff. Oh my gosh, all the nutritional stuff. Women need more protein. They need more trace minerals. They need more collagen. Have you had a fatty acid analysis, amino acid analysis, all these things to see, are you actually absorbing what you eat? So all of a sudden, nutritionally wise, you might just be malnourished. Everybody I see has a deficiency in something nutritionally wise. If you haven't had a full nutritional panel, sometimes just fixing your amino acids, proteins, your vitamin D levels, your B vitamin levels, sometimes that's all I need to do with patients to make them feel better. So all of a sudden, with the 5 things you said, I've already mentioned, a bunch of things that I look at on everybody because it's the foundation everything else is built on,
Yeah. And so I'm smiling only because this goes way beyond just making sure that you get 25 to 35 grams of fiber in your diet every day. I mean, that's great and that helps,
Yeah.
right? But what you're telling me is that there's this whole theater of things going on in your gut that we're only getting to one little piece of it by just adding more fiber.
Yeah, and one of the things I do with all my patients is there's the thing called predictive autoimmunity. And the idea is that it's very common as we get older to get more inflamed. It's called inflammaging. As you get older, you get more inflamed. And part of that is autoimmunity. And that doesn't mean you have lupus or whatever, but many women will develop thyroid antibodies, will develop a rheumatoid factor, elevated sed rate, elevated cardiac CRP. And just finding these inflammatory markers elevated lets me know which part of your immune system is off, out of kilter. That's a standard evaluation. And it's interesting how many women will come in and have thyroid antibodies. And all of a sudden, this is part of your brain fog, fatigue, hormone, osteoporosis, osteopenia, is this your body's actually attacking itself. And then there are some basic things, interventions you can do, but that's like a screen for me. That's everybody gets that. That's not optional. Autoimmune diseases by themselves are the most common disease. If you add them all together, are the most common disease in our country. And it's something like between 10 and 20% of Americans, depending on which population you're in, will have a positive autoantibody. So why isn't screening for that standard in regular medicine? And it's because until you get a disease like, rheumatoid arthritis, the traditional world doesn't have a treatment for it. But in my world, it's great, let's address toxins, leaky gut, let's address your immune status. And you can actually get these autoantibodies to actually normalize over time. And I've had that happen to hundreds of patients.
Wow. Okay. This is so exciting. And I want to pick up after the break here about cardiovascular disease, because I think we could go down a rabbit hole on this one. So we'll be right back. Before we jump back into today's conversation, I want to ask you something. If you've been listening for a while, you know this podcast isn't fluff. We talk about muscle, metabolism, hormones, brain health, longevity, the stuff that actually determines how we live in our 70s, 80s, and beyond. And the show keeps growing because you share it. So if an episode has helped you rethink your health, send it to a friend, text it to your sister, share it with your walking buddy. That's how this community expands. Smart, curious women bringing other smart, curious women with them. Also, I'd love to hear from you. What topics do you want me to explore? Who do you want me to challenge? What questions are you afraid to ask but secretly want answered? You can use the link in the show notes to join the community or send me an email with your ideas directly. This podcast exists because you're asking better questions. All right, let's get back to the episode. Okay, we are back. Before the break, we were talking about autoimmune disease. I'm going to back up real quick here. How do we get our primary care doctors to do some of these tests if we suspect we've got an issue?
So I actually, one of the resources in my book, actually, Uncurable, is that how to talk to your doctor section. So kind of like this little video thing I did and some check, how do you, if you have 15 minutes, how do you, and so part of that is you have to realize, there's only so much you can do in a 15-minute time slot. I think the current data point is the average person spends 8 minutes in a doctor's office. So it's so you have to go in there prepared, ask two, maybe three things tops. You have to, hold your excitement down and say, hey, I'm feeling kind of cruddy. Would you mind checking my thyroid antibodies? Because my thyroid panel, and checking my D level, and maybe doing a fatty, just a few things. And for me, when patients came and asked me those questions, I was always curious. I'm like, what's a thyroid? I mean, I know that endocrinologists do that. Who am I to do that? Sure, why not? And then it comes back and it comes positive. I have to figure out what to do with it. And that's kind of actually one of the things I started doing early on, was just ordering stuff and learning from the stuff I was ordering. If you're not working with someone who's even open to the idea of doing anything outside the box, which is a lot of people, 80-20 rule, 80% of people are going to do what everybody else does, right? So you have to find someone who's thinks a little different, who's open to working with you, And then if they order it, you have to be willing to do a little legwork on your own, right? Because, if you're in a busy practice, the way I learned how to do this, I was getting up with my daughter. Part of the story is when we got here, I realized I had to figure things out. I was getting up at 4:00 in the morning, reading research articles, reading doctors' opinions, reaching out to people for 2 hours in the morning and then an hour at night. So I was spending 3 hours a day of my own time figuring this stuff out. So I learned a lot really quick. But most physicians don't have that time. I've invested hundreds of thousands of my own dollars into learning about this. So you have to realize that most people don't have the margin for that. And so you have to be willing to do some of their own legwork yourself, show them some grace, be patient. But ultimately, if the person doesn't have the temperament to work with you, and they're like, that's not standard of care. You don't need to do vitamin D levels on people. They're all low. Just take vitamin D. We don't check A1Cs on you because you're not diabetic. I'm like, well, A1C you can predict my risk for diabetes over the next 10 years. That's not a big deal. And so if you don't have a person who's at least open to it, which is a lot of people aren't open to it, then you might need to find someone else. But I did a whole thing on this about how you actually work through this. It's a big deal because the reality is if every doctor in our country went to functional medicine, we would need 10 times more practitioners than we have now to meet the current need. And we still don't have enough, right? So the reality is there's not enough people out there like me to meet the need for everybody. So
yeah, and as you're sitting here talking, I'm going, I have to ask my doctors for certain labs, and they'll say, well, why do you want that? And I'll say, well, because I want to check this, this, and this. So I've done my homework, but what you're saying is some of the onus is on us to make sure that we are doing that.
The one thing you can, LabCorp and Quest actually have discount labs. You can get your own labs. You just pay cash price. And they actually have special prices that are about 10 to 20% the sticker, so you can get an A1C for $12, right? You can get a vitamin D level for $20. So you can actually, if your physician isn't going to order it for you, you can just pay cash and go online and order it to these places at LabCorp or Quest and order a lot of these things. That's an option as well. But then again, the onus is on you to then you get the results back to figure things out. But I always tell people to start with basic, B vitamin levels, B12, folic acid, homocysteine levels, a mega check, which is a blood fatty acid analysis, antibody tests. So there's a lot of basic things you can do. Vitamin D levels, there's a lot of basic things you can do on your own, but then the onus is on you to figure out what to do with them.
Are those in your book? Any of those suggested tests?
Those, I do. Oh yeah, I do have a whole section that talks about things I did with my daughter and tests. And I don't think I actually mentioned, if I recall, sometimes I say so much stuff, I forget what I say where, but I don't know if I mentioned the actual, lab companies, one's One Lab, but they're not hard to find because they're all putting ads up. So,
all right, great. All right, I want to talk about cardiovascular disease, and in particular because right now I'm working through the American Heart Association for the Go Red event to raise more money and awareness around women and cardiovascular disease. So I have a kind of a soft spot because I've worked in the cardiovascular metabolic world for most of my previous career, and I was wondering, beyond the fact that cardiovascular disease is the leading cause of death in women, are we missing early warning signs in midlife that this is impending?
100%. One of the things I do talk about in the book and I talk about on social media a lot is this idea of medical gaslighting or medical blind spots. And unfortunately, women hit the brunt of that. Great example, it's funny, most of the studies on men, middle-aged men, Caucasian men until recently, and women tend to present with heart attacks, more stomach pain. So literally women would come in, I got reflux, my stomach's off, it's just your anxiety. And they would be having angina, but women present differently. And it took us, I remember that was cutting edge when I was, oh my gosh, cutting edge. Women look different than men with heart disease. And you're like, well, they kind of sort of are different. And so, 100% early things. But the thing about that is people start developing heart disease in their teens and early 20s. We know from autopsy reports that teenage kids will already have soft plaques. So the question isn't, don't wait till symptoms. That the heart disease you have when you're 60 is a plaque in your 40s, which was vascular inflammation in your 20s. So the better question is, can I actually do lab testing? And the answer is yes, by the way. Can you do lab testing that picks up dysfunction in the lining of your arteries, inflammation, immune dysregulation, which are the three causes of all heart disease? Can I pick those up, in my 20s and 30s and actually prevent the whole thing from going forward? And the answer to that question is yes. And a data thing for you, this was actually published by the NIH. They're legit. I think they're still legit, right? November of 2024. And you can predict of females 30-year risk for heart disease with 3 numbers. It's your hs-CRP, which is a marker for inflammation in your arteries, your LDL particle number, okay, which tells you big, small stuff, and then a lipoprotein A or LP little a. Knowing those 3 numbers, and if they're high, you're like, oh. And if they're low, it's like, wow, you are now in the low risk, and that can help predict your risk for the next 30 years. So my thing is like, shouldn't every female get those 3 labs done?
Yeah.
You know, and the other data point for you, in general in our country, 30% of all heart disease is directly related to lead exposure.
What?
Okay. Is directly related. This is EPA data. This is not Dr. Hartman. This is government data.
Okay.
And of course, and that's older people, people in our age range. I'm 52, turning 53. If you were born before 1991, you were exposed to lead, whether the paint, the gas, whatever. So all of a sudden now, if you're a female or a male worried about heart disease, what's your blood lead level? It should be undetectable. And if there's any in there, that's a bad thing. So those are 3 labs in one medal that everybody who's concerned about their heart, and you can get into genes and a bunch of other stuff, but those are just super basic things that have big, big bang for your buck.
All right. So then I have to go to LDL because everybody uses that as your marker because, you've got an LDL of 140. We need to throw you on a statin. What else do you look at before you suggest a statin?
Well, the question is what's the LDL made of? Is it made of really big, fluffy, healthy particles, or is it made of hard, dense, damaging particles? Is it oxidized? Oxidized LDL is horrible. That's actually a marker for burning, actually, in the cholesterol molecule. So tell me about the kind of LDL, and the answer is they don't check those things. And so the LDL, it's the devil's in the details. LDL by itself is not bad. It's like, what's it made of? And then HDL is another one. You might have a good HDL number, but is it functional or dysfunctional? You might have a female of a 50 or 60 HDL, but if your HDL particle number, which is an indirect way of looking at the functionality, or now Quest Labs through Cleveland Heart Labs offers an HDL function test, is your function low, right? So all of a sudden, all these details, and I can ramble on about this aimlessly, so I don't want to ramble on too much, but the question I ask people is, what's the ultimate cholesterol number for all-cause mortality? My clinical research company, we do studies, and the question was all-cause mortality, like, dying for any reason, right? And there's an ellipse, this thing called it's like ellipse J-curve. And if your cholesterol is too low, you have an increased risk for dying of all causes. And that's like more neurological and cancer. If it's too high, you have a risk for dying for things that's more cardiovascular. That number that you have the longest, the best outcomes is between 220 and 240. So it's not 170. Now, if you're a diabetic, that's different. If you've had a heart attack, that's different. I'm talking about in the general population, right?
Yeah.
Concern with women with statins is that statins increase your risk for developing diabetes, maybe up to 48%.
Why is that?
We don't quite know. It's in postmenopausal. It's menopausal women, not less than, but it can significantly increase your risk for developing diabetes. And so I give you a statin and lower your risk for heart disease 25%. I'm a good doctor. I did a good job. If you get diabetes, I just increased your risk for heart disease 400%.
Yeah.
Right? So if you're a female on a statin, I want to see your fasting insulin and your A1Cs. And if they're tracking up, stop it, see if it comes down. If it does, then I know you're statins. Well, actually, I guess I do know why statins. I'm sorry, I do know why. I'm sorry, I didn't think about this. Sorry. I do know. Statins are actually toxic, mitochondrial toxicants. They actually are toxins to your mitochondria, which is the powerhouse of your cell. They also induce CoQ10, which is a nutrient required for energy production deficiencies, B12 deficiencies, folate and magnesium deficiencies. So any one of these can actually increase insulin resistance. So if you're a female, male, or anybody taking a statin, are you supplementing with at least 100 to 200 milligrams of CoQ10? And are you taking a good B supplement that gets all the Bs in there? And then add in some magnesium as well, because it can also cause magnesium deficiency. And by the way, 80% of Americans are magnesium deficient anyway, right? So how many people are recommending that? And the answer is very, very, very few.
Okay. Now, I hear this in my research and stuff, that if we lower cholesterol too much, it can increase the risk of dementias, that our bodies, our brains do need fat. So how do we parse that out with too much is not a good thing? To
my point, it's not just cholesterol. Like what are all these other markers? What's your LDL particle number? What's your size? What's your hs-CRP? What's your homocysteine level? Vitamin D status. Your vitamin D being low increases your risk for cardiovascular disease. What is your omega-3 level? There's a thing called omega-3 check. Here's a great data point for you. If you're omega-3 levels are low, you have an equivalent risk for heart disease as a smoker with a normal omega-3 level.
Holy cow.
So like that's the way the literature presenting. So my question is taking omega-3s as good for your health as not smoking? Like, because that's what that suggests. And how hard is it to check an omega-3 level and replete it? And the answer, it's really easy, right? And so the question you need to ask is not what is your cholesterol? That's 20th century thinking. 21st century thinking is, the three causes of cardiovascular disease are immune dysregulation, inflammation, and endothelial dysfunction, which is dysfunction in the lining of your arteries. The question is, what labs correlate with those things being off? Oxidized LDL, elevated LDL particle, hs-CRP. There are some genes like an ApoE4 gene, which is related with inflammation, fibrinogen levels. There's a lot of other labs. So we're like, and the data I'm talking about, this data is like 20-some years. It's old now. It's decades old. It's not new. But medicine takes decades to pick up things. So we're still practicing medicine. And that's the standard of care. Standard of care lags the literature sometimes 40 or 50 years. So the questions you're asking are good questions, but they're just acknowledging a phenomena that the practice of medicine lags the literature anywhere up to 30 to 50 years. And so your problem is you're stuck in that because you're learning this and you're like, well, I learned this, but why is this the standard of care? And it's like, well, standard of care is always going to be lagging the literature by decades.
Yeah. All right. One other question about LDL. You have ApoB and you have LP little a.
Okay.
Right? Is one of those hereditary?
The LP little a, so this is, the mantra is, the science is, I say science because science changes all the time, right? So the science is that LP little a is genetic. So you don't have to check it a lot. You check it, it's high, low, to your point. But I have patients who have come with LP little A's, 240s, 250s. I got them still elevated, but down to 170, 160 with some interventions. So I have to ask myself, if it's that genetic, how can I change it with nutrients, things like omega-3s, things like berberine, things like aged garlic? How can I change that, the number, vitamin C and acetylcysteine? How can I change it if it's only genetic? I think the setup, like anything, the genes load the gun, the environment pulls the trigger. I have one patient, his grandmother's in her 90s, his mom's in her 70s, and he's 40s. And they all have high cholesterol. They all have high LP little A's. And he's freaking out about it. I'm like, and his family's from the islands. And like your grandma, she's never had a heart attack, right? Oh, her cholesterol's like, 300. Huh. How about your mom? Same thing. And they all have this LP little a thing. So it does increase your risk, but the point is it's not determinative. And you can do things to lower it. I think that's the big picture.
Okay. I had to ask that because we hear of familial hypercholesterolemia, and I didn't know if that was different.
That's a different thing. Familial hypercholesterolemia is actually a genetic thing where you have like 3, 4, 5. That doesn't apply. That's a different thing. That's actually a different gene thing where you have like, 3, 4, 500 number cholesterol, and you have a family. And it's like my dad had his first heart attack when he was 35 or 40. People are having events in your family at a young age. So that's those people, the PCSK9s, which are some really fancy drugs, high-dose statins, like the reason we have those drugs is for those people. That's brilliant for them. But that's a different creature altogether.
All right. Thank you for defining that because that does come up from time to time with clients of mine. And I want to cover off on that. Okay. I want to talk about the thyroid. And I think this is one of those things that gets missed very often because we do some general testing, but we don't go deep enough. On the thyroid front, is TSH alone adequate? And when do you expand testing to free T3, free T4, or antibodies?
So TSH is adequate for screening in a population. So if I'm just going to screen the population, screen 330 million people for thyroid disease, just check 330 TSHs. Is it good for finding out thyroid optimization and subclinical people that are on the borderline for having? And the answer to that question is no. And so I see people, individualized stuff. I'm not seeing 330 million people. You come to me, what about my thyroid? I'm not going to tell you what I would tell the exact same thing to the next 339,999. And so everybody gets a TSH, third generation TSH, gets a free T4, It's a free T3, which is the actual active, T4 is kind of like the storage form. It's 10 times less potent than than T3. That's the active form of thyroid, though T4 has some actions. Reverse T3, that is literally the brakes to the whole thing when your body has the T4. Mitochondria actually will turn T4 into either T3 or reverse T3. So it's a way of your body saying, whoa, something's going on here. I need to hibernate or something. So reverse T3. And then thyroid antibodies as well. I put those are all part of my standard, which is TPO and anti-thyroid globulin antibody, part of my standard protocol panel, because you ultimately don't just know what the brain is saying. Because you had a brain injury, a traumatic brain injury, or an infection that might affect your brain saying, I need to hibernate. So what's your brain telling your thyroid? And then what's your thyroid doing? And then what's your body doing with what your thyroid tells it to do? So I look at the whole cycle, not just one piece of the puzzle.
If a woman comes into your office, and you may suspect, and I know you do these tests routinely, but for my audience, how might they self-diagnose that they may have some kind of thyroid issue?
Well, thyroid issues can sound like hormone issues, can sound like cortisol issues, can sound like a lot of things. But typically it's hair loss, I'm cold, my cycles are off. You could be having more menopausal hormone cycles related to your thyroid as well. Brain fog, weight gain. You tend to get like a little swelling. You can get like this thing called myxedema where you get kind of puffy, constipation, poor sleep, poor resilience. You wake up feeling tired. I already said hair loss, thinning of your skin. There's a whole host of things that can be related to hypothyroid. And hyperthyroid, which is the other side, is usually the opposite of everything I said. Lots of energy, can't sleep, maybe a little manic. You feel hot all the time. You get diarrhea. You're warm. Your hair grows fast. Like you're losing weight. You feel like your heart's racing all the time. So not a direct correlation to like those two, but
all right. Well, I'm not sure. I'm like, which one would I want? We're probably neither, but
neither one.
Yeah. I see where this can kind of mimic when your cortisol levels are high too. So that's kind of an interesting call out. Are there common nutrient deficiencies you frequently see in midlife? I know we talked about vitamin D. What about ferritin?
Iron deficiency and iodine deficiency I see all the time. Iodine deficiency is very related to where you live in the country. Like there's a goiter belt in the Midwest where all the soil is low in iodine and people get lots of goiters. So you won't have adequate iodine. And the ferritin, iron is a super important part of thyroid function. You need adequate iron, and those are the two most important mineral. Well, selenium iron, which ferritin is the active form, and then iodine. The thing about ferritin, it's not a standard test that's done. Usually they do a blood count, which is CBC. Maybe with hemoglobin's 12 or 13, that's normal. But if your ferritin's like 8 or 6 or 20, you have a low level of functional iron. And that could affect hair, skin, you get little ridges in your nails, and it affect your thyroid function as well.
Is that an expensive test to run a ferritin test? Okay.
No, ferritin, selenium iodine tests are not expensive to run.
All right. So we talked about doing an omega-3. What about vitamin B levels, B12? Are those pretty standard?
In the regular world, no.
All right.
In my world, yes. Yeah, but you typically order B12 level of folic acid. I also order a homocysteine and methylmalonic acid. Those are two organic acids. They're breakdown products of the metabolism of those vitamins. So you can have a blood level normal of folic acid and B12, but not get enough in your cells. So you can be functionally low B12, functionally low folic acid, and you won't pick that up unless you do a methylmalonic acid or homocysteine. And the homocysteine level being elevated, and both it's counterintuitive. Both of these are high when your nutrients are low. An elevated homocysteine level is associated with autoimmune issues, inflammation, dementia, neurovascular disease, cardiovascular disease. So just knowing your homocysteine by itself actually improves cardiac outcomes, right? So those are standard things that everybody should get as well.
All right. But back to the lab testing. Is there normal versus optimal on homocysteine?
100%. There is. The normal, it depends like a LabCorp quest. Normal usually is less than 12, but optimal is 6 to 8. Same thing for TSHs. Normal is anywhere from 0.5 to 5. Optimal is like, depending on which lab it is, like 1 to 2. I try to get as close to 1 as possible. B12 is a great one because the normal range on that's like 250 to like 1,000. But the literature, the medical literature, PubMed literature, is that if your vitamin B12 level is less than 500, you have an increased risk for neuropathy. So I want all my patients to have their B12 levels over 500. So all these labs have those nuances of normal range versus optimal range.
So is neuropathy an issue beyond having diabetes?
100%. You can have it from heavy metal exposure. You can have it from toxins and chemicals in the environment. You can have it from nutrient deficiencies. There's lots of reasons to have neuropathy.
Okay. Oh, that's really interesting. That never on my radar. But okay. I want to talk about estrogen. I know. This is my audience, though. We have to talk about it.
I've talked so much about estrogen the last year. I love estrogen. It's great.
Are you estrogened out? But there's so much opinion that runs the gamut on when is it appropriate to start estrogen. So what are your thoughts?
So my question is, when are you okay losing your heart and your brain? Then you don't need estrogen anymore. So that was meant to be shocking. This is an example of medical, either blind spot or gaslighting, depending on what your worldview is. So as of November 2025, we can do estrogen again, right? Black box is gone, right? Mm-hmm. According to the medical, and this is just literature data, anybody can pull this off of PubMed, and with AI, you can figure it out now if you have the right prompts. But hormone replacement therapy lowers a female's risk for heart disease 50%, and your risk for dementia about 35%. So according to the literature, and Dr. Blind Spots, Marty McCary wrote a book about this called Blind Spots. He actually quotes these data points in that book, that potentially 140,000 women died prematurely in the United States due to lack of access to hormone replacement therapy from 2002 to last year. So this is a big deal. 40 to 60 million women were undertreated. And I don't know why people aren't really up in arms about it, because it was a big oops, a big miss. And it's, when should women start getting, most of the bone loss, osteoporosis, most bone loss occurs during the first 2 years of menopause. So you really want to be watching your hormones as you're going into the change of life. The first 10 years after that are the most important for neurological, cardiac, and bone health. But estrogen is important for brain health. It's important for your skin. It's important for tell a guy he doesn't need testosterone. Estrogen does in men and women what testosterone does in men. So what age do men not need testosterone anymore? The grumpy old guy who's,
Yeah.
You need it when you're 80. You need it when you're 80. And so it's the same thing with women. Women need it when they're older. And so if you want to be 80 and have your mind and be active, have your bones stable, then you need it. There's no limit to when you can get it. It's just, I think the devil's in the details. It's how do you get it? Do you topical? Do you do oral? Do you do creams? Do you do pellets? That's where I think the details are. And never do oral estrogen, because that's where that's where you get in problems. And never do oral Prempro, which is horse urine, estrogens, equine conjugate, and and it has medroxyprogesterone, which is known to cause tumors in lab animals. So it's of course, if humans eat that causes problems. Don't use that.
Okay. When you are looking at a woman who is perimenopausal, do you ever suggest estrogen for someone in perimenopause?
100% depends. I actually check the hormone levels. I don't guess. Typically what happens is women late 30s, early 40s, their testosterone will start kind of going down. And then early 30s to late 40s, their progesterone will start going down. And the estrogen will actually start going up and start doing this kind of wavy thing. So what happens is a lot of these symptoms that might look like estrogen's up or low, whatever. It's actually a dysregulation, an imbalance between these. So what happens a lot in the early perimenopause area is you're doing a little bit of testosterone, you're doing a little bit of progesterone. And this is where, now I'm going to take a side step here. You have to honor the hormonal hierarchy. And sex hormones at the bottom of the hormonal hierarchy. The top is cortisol, insulin, and thyroid. So if your cortisol is off, you're insulin resistant, and you have subclinical hypothyroidism, it's going to make you have sex hormone issues, particularly in this age, and it's going to make them worse in this age group. So you have to address that. And all your sex hormones are detoxified through your gut. So you got your gut squared away. So I don't want to say too much about that, but you got to respect this hormonal hierarchy before you hop into hormones. So that aside, with the hormones, I tend to do more with progesterone, testosterone early on, and then just track the estrogen. And what I do a lot of actually is detoxification of estrogen, because what I see a lot is estrogen dominance, heavy periods, fibroids, fibrocystic breast, right? In the face of low progesterone. So you get abnormal bleeding, spotting bleeding, all that kind of stuff. And that also can lead to some of you don't tolerate stress. Your sleep is poor. That's a progesterone deficiency thing. Your libido is off. You're losing muscle mass. That tends to be a testosterone related things. So all of a sudden it's a little more nuanced. It's not all just about estrogen, though estrogen is it does give you your superpowers. So you have to look at all those things.
It's funny, you talked about testosterone, and I get so frustrated when people think of testosterone as a male hormone. I'm like, no, women have testosterone too, and it needs to be replaced.
Well, how many of your friends, colleagues have issues with recurrent UTIs, painful intercourse, atrophy of your external genitalia? The outer 1/3 of your female genitalia are testosterone sensitive tissues, androgen sensitive tissues. So if you're female, and I see this a lot in my 60-year-old range, well, they'll come in, I love my husband, it's painful, I have intercourse, it's thinning, I've got lichen sclerosis, lichen planus, these things. A lot of those actually are testosterone androgen deficiency issues. And so if you want your body parts to not get UTIs, not be painful, and not to get these little ulcers and things on them, you actually need adequate testosterone for that stuff.
And vaginal estrogen, correct?
Well, you can use that as well.
Yeah.
The vaginal estrogen, it's nuanced. The vaginal estrogen, again, the outer 1/3 is more androgen sensitive, though of course estrogen as well. The inner part is more estrogen sensitive, and also depends on the reason why you're using the estrogen as well. So
got it.
Test, don't guess. Right now I'm guessing. You can get the testing done and figure out what's off and just address it.
I have to ask you this. Do you have an optimal testosterone level? So say you put me on testosterone cream. Do you have an ideal level where you like to have your female patients?
It depends on this is where it gets tricky because every lab has a different reference range. Mm-hmm. And so I look at your testosterone being the third to fourth quartile. So take that normal range, whether it's a blood test or a Sitbit test or, those are the two major ones. And you basically cut it up into fours and look at what the top quartile is and just kind of put the level right in there. And then with testosterone, you want to make sure that, it can turn to estrogen. So you kind of follow up on that as well. But I try to focus on the third to fourth quartile.
Okay. I'm laughing only because I do a topical testosterone therapy, and I was noticing that I was getting, some little extra chin hair and those sorts of things. Those are nuisance things. But I also noticed that my sex drive was probably getting a little kind of my husband was happy, but I was like, okay, this isn't normal. And I went back and got tested, and it was a little high. It was out of her comfort zone. So we cut my dose. So anyway, that's sometimes TMI went on the show, but I don't really care. All right. I want to discuss a little bit about detoxes. So you say, you may detox someone of estrogen. What does that mean physiologically when we do some kind of a detox?
Well, your body naturally takes estrogen, you conjugate it, making it water soluble, you put it in your bile and you poop it out. So improving women's detoxification is just helping you poop better, help your liver work better to detoxify that. So if you're chronically constipated, you're going to have estrogen detoxification issues. If you've got the wrong kinds of bacteria, if you've got an elevated beta-glucuronidase, is a stool test that you can do that shows you're actually uncoupling this whole process and reabsorbing the estrogen, so it can tend towards estrogen dominance. Then you can improve the liver function. That you can do that with things like olive oil, DIM, sulforaphane. Certain amino acids. Actually, part of detoxification requires protein. One of the things you probably know pretty well in your age range, you need more protein.
Right.
Having low protein is going to affect this phase 2 detoxification. It'll affect how your body gets the stuff out of your body. Sulfation, glucuronidation, just getting more amino acids. So that's what you're talking about when you talk about detoxification is your liver binding it, putting it in the bile. And curcumin helps with that. Dandelion helps with that. There's a lot of herbs that help with that. Get it into your gut and then get your gut to move to get it out of your body. That's what the process is.
So it's not just estrogen. It's other things too that we need to have this. We need to have a good detoxification system just in general.
Yeah. And one passion I have, I shouldn't say passion. One point I make a big deal about is sweating. A lot of solvents, a lot of these neuroendocrine disruptors, which are chemicals that act like hormones, are actually excreted through our sweat. Now, the question might be to you, when's the last time you sweat profusely? And the average American doesn't sweat at all, 100 years ago, you would sweat, all day long, all summer long, depending on where you live in the country, in the fall as well, We don't sweat anymore, and people forget that's one of the ways we detoxify. So it's not just pooping. It's not just drinking adequate water. It's not just eating clean food, breathing clean air. It's also, do you sweat profusely 3 to 4 times a week at a minimum? The answer is no. It's going to impact your detoxification process.
And so do you suggest a sauna?
The best way to sweat is to be physically active outside, moving your lymphatic to sweat. I realize that means working outside. Okay, so most people aren't going to do that. Saunas are awesome. They actually help. There's actually lots of great Finnish saunas. In Finland, there's a lot of data on. Actually, here we go. Back to your point. This is male data because, the whole medical gaslighting thing. But you can lower your risk for heart disease 25% by being in a sauna 3 times a week and lower your blood pressure 10 points. So literally doing a sauna 4 times a week acts like a blood pressure medication. So all of a sudden, sauna has cardiovascular protective benefits to as well as detoxification. But saunas are great. I try to use mine 3 to 4 times a week. And it's very calming as well. It's a great part of an afternoon process if you have one at home, just to get in the mood to fall asleep. If not at the gym, just use it after your workout. But yes, saunas are good.
Okay. I told you we were going to talk about this because I'm curious, but parasites. I hear about parasites like, oh, you need to do a parasite cleanse. Give me the skinny on parasites. Are we really at risk for parasites?
I mean, we have lived the majority of human history, actually 99% of human history has been with parasites. It's interesting. Countries, sub-Saharan Africa countries where parasitic infections are endemic, you don't see autoimmune diseases, you don't see cardiovascular diseases. There's a whole field of medicine looking at parasites as a thing that modulates your immune system. There's actually I've got some patients that are autistic that I've actually given oral parasites to calm their gut down for their autism. And I got these from Duke. I specially ordered these parasites. It's actually a porcine, doesn't infest people. But so there's that thing. Like, not all parasites are bad, but put that aside. The problem is you have to be a healthy host. If you're an immunocompromised, sick, inflamed host, parasites go crazy. Just like your gut microbiome. Are all bacteria bad? No, we need the 100 trillion bacteria. Are all viruses bad? No, 8% of our DNA actually is viruses that introduce themselves into our DNA. Parasites is a very similar story. I don't know where to go with this, but there are a lot of patients I see who have chronic fatigue, fibro, who have multiple nutritional issues, B vitamin deficiencies. They got SIBO, gut IBS. Those individuals, they can have parasitic infections that have overgrown, that are now activating their immune system, just like you can react with meat and gluten and dairy and soy and all this other stuff. So can you now have a dysfunctional relationship with parasites? And the answer is 100%. The other thing about the parasites is in modern culture, most parasite exposure is actually from your indoor pets. So are you going to get rid of your dog or your cat?
No.
And and you give them a dewormer. It's funny, like we give our animals dewormers like every 6 months. When I go to Guatemala on a mission trip down there, I go to this hospital in the middle of nowhere, at the schools. We go to schools literally and just give the kids dewormers.
Really? Okay.
Because they're so common. So parasites are a thing. They're everywhere. They're common. Some of the gut testing I do does look for parasites. And when I have patients who are chronically ill, I will do an advanced parasite test. There's only one place in the country that does it. And some people, it makes a big difference. But just like all bacteria are not bad and all viruses are not bad, all parasites are not bad. Devil's in the details. Do I test for them? Yes. And if I'm seeing someone who has health issues, who's sick and is autoimmune, do I treat them? Yes. But if you look for parasites in healthy individuals, you'll see it in a lot of people. Quick aside, most ancient cultures that have a healing tradition, like Ayurvedic medicine, traditional Chinese medicine, will have a seasonal detox cleanse of some sort that does a parasite cleanse, right? It's usually cinnamon, clove, artemisia, oregano, which all these things also balance your gut bacteria. They also improve detoxification. So these cleanses people talk about are not solely parasite cleanses. They're also rebalancing their gut bacteria. They're also a detox. So you have to keep that in mind as well.
All right. I had to ask. It was just burning question that I've had. I want to talk a little bit about longevity medicine in general. I think we can talk about lifestyle all day long. We know that lifestyle is imperative. Good lifestyle is imperative. Looking ahead, though, what emerging tools or therapies in longevity medicine are you most excited about?
I think the funny thing about longevity medicine right now is we're looking at all these cool things, cool gadgets, cool technologies, stem cells, exosomes, peptides, vibrating foot plates, clothogene, all these really this cool stuff. If you dig into the science and look at how they work, they're just doing what high intensity interval training, physical activity does, what fasting does. And so I think in my mind, all this cool stuff is cool, but it's reinforcing to me, you have to perfect the basics. If you have a clean diet, rich in nutrient-dense foods, you're getting accurate protein, clean protein. If you have meaningful relationships, blue zones, places where people live to be 100 more than anywhere else in the world, don't have access to cool biohacks, don't have access to hospital and cool labs. They eat real food, they have family, they're outside a lot, and they live for a really long time, right? So I feel like a lot of the cool technology stuff, it's awesome and cool. I love it. I do it all. I'm done with my daughter. We've done all kinds of cool, NMS, neuromuscular stimulation, hyperbaric, all that. But that should always be on top of the foundational stuff. The foundational stuff is by definition foundational. And for me, I get what you're saying where, what's my new cool, my cool hack right now, I guess, is lipid therapy, using fats to heal your brain, which is like 40 years old, the new thing. It's a new thing. It's really old, right? But really it just speaks back to, sitting is the new smoking. Literally sitting around being inactive is as bad for your health as smoking, right? So all of a sudden, do we really need a new supplement or a new peptide or a new zappy device? Or do we need people to be more physically active to get chemicals out of our food? So I tend to focus on the things that the average person can do. And that's actually the most important thing to do. And then once you're doing that, cool, let's talk about, here we go. I love this. Here we go. Cancer stem cells. You can use things to actually remove senescent cells to remove cancer stem cells. Quercetin, cumin, turmeric, apogenin. These are really cool things we're learning now, that actually when you have these senescent, kind of old, crumpy dead cells, you can remove them and improve telomere length, right? That's a cool biohack. But if your diet's horrible and you don't sleep and no one likes you because you're a miserable person, you know what?
Yeah.
You probably won't make it to 100 with all your health,
Right. Yeah. And I think that's a great point. I've done, the resting metabolic rate test, and I've done a whole full body DEXA scan, and those things are great for data points, but that's not necessarily going to help me live to be 105. So
you want to be able to be 105 and have your mind, have your health, and be able to interact with your great grandkids or whatever. You don't want to be slobbering on yourself. And I look at blue zones, places where people do this on a regular basis, and they don't have all the cool fancy stuff we have, but real food, physical activity, meaningful relationships, and the environments by nature aren't filled full of toxins because they're not in the middle of New York City or Chicago or whatever. They're Okinawa, Nicoya, Costa Rica, Sardinia, Italy, and then Okonos. The one that's kind of interesting is Loma Linda, California, which is Seventh-day Adventists. Their community is a blue zone, which speaks to faith and family, because that's a big part of that blue zone there. But the point is that these are basic things that we all should be doing and we all should be perfecting. And then let's do all this other cool stuff as well.
Yeah. Can you share a patient story of a woman who was told everything was normal? She came to see you and you were able to get some improvement by looking a little deeper.
Well, I can talk about I have lots I can talk about. I can talk about my lovely wife, who we talked about her before in our podcast. She had a lot of chronic fatigue, fibro, brain fog. She actually lost 5 years got horrible debilitating fatigue after pulled a nerve in her neck, got in pain, went to the doctor. There's nothing wrong with her, gave her steroids, and she was in bed for basically barely functioning for 5 years. And come to find out, what started this was a stressor, was the life event of, actually adopting our son, bringing her house, and then she pulled a nerve in her neck, and they got steroids, and it pushed everything over. But underneath that was actually toxicity. She actually, in an anatomy lab in grad school, you were around formaldehyde for half a year, and she got a massive formaldehyde hit. And during that point in time, her anxiety got really bad. She thought about dropping out of school multiple times and didn't. And then as school went on, she got better and better as she got away from anatomy lab. She had some issues with toxic shock syndrome as well. She actually diagnosed her own toxic shock. Balancing hormones, GLP-1s for inflammation, yada, yada. But she's now doing great, thriving. But there's 5 years of her life that she kind of lost, because she literally was just, I'd come home and she would go to bed and sleep, and I'd take over and make meals and stuff. And that's an extreme version. But I can give here's another example of someone that started seeing in her 70s who had chronic fatigue and fibro, brain fog from her 20s. And she came to see me. And on our first visit, I diagnosed her undiagnosed Lyme disease. No one ever thought to do a Western blot Lyme titer on her. And 6 months later, 80% of her symptoms were gone. And then we started talking about her hormones. And of course, her hormones are off. So we started replacing that. We're already working on gut. And now we've been working together for 4 years and she feels great. But it's interesting with her because in her mind, she's still like waiting for I was sick for 40 years. Like, when's it going to all come back? And so every time she has like a little setback, she's always like, I'm like, look, you're doing so well. You're doing awesome. And it's funny how when someone's been sick for a long time, you get like a trauma brain. I see this all the time with patients. You're kind of expecting, okay, what if it comes back? And that's one of the things you have to learn to retrain your brain. I work with a lot of trauma with patients as well. Because if you've been chronically ill for a while, it does affect the brain wiring and does put your body in this fight or flight situation. And so that, with a lot of my patients, becomes a big part of their healing journey as well. Once they've worked through all the basics, right?
Yeah.
That how do we rewire your brain and work on that stuff as well? So, I have another story that's popped in my head. But yeah.
Yeah. You gave her life back. That's incredible. And so this is where this is my pep talk to my listeners and even my clients and my friends is don't put up with status quo, get answers, be curious, do the research, but be your own best advocate because we can't solve issues if we're not putting it out there and asking the right questions. All right, this is a question for you. This is a personal question. Besides the sauna, what is your single most important daily health habit that you consider a non-negotiable?
I just eat real food. I don't eat anything processed. 80% of heart disease and 70% of most cancer can be prevented by diet and lifestyle alone. So I just eat real food. It's amazing how just eating real food, how that much of a difference. The devil's in the details though, because when you say real food, you're like, well, what do you mean? I'm like, well, it's not milk you buy at the store. It's not bread you buy at the store. It's not the ultra pasteurized. They heat it to like 280 degrees and burn the milk from cows injected with bovine growth hormone, that are fed glyphosate laden, soy and corn that's genetically modified. It's like, that's not the milk we have at our house, So the devil's in the details. And that's actually a resource in the book as well as like a food sourcing guide where people can figure out how they can find real food wherever they're at in the country. So, but that's like the non-negotiables, just eat real food.
Yeah. Yeah. I love that. And then Dr. Aaron Hartman, where can the listeners find your work and your book, Uncurable?
So I have, a bunch of things, podcasts, social media, YouTube, but the hub for all that is just aaronhartmanmd.com. That's a website you can go to. They'll take you to, all those things. Just start there and then you can hop from there, wherever, including the book. And the book you can go to from aaronhartmanmd.com or uncurablebook.com. And then you get the book on Amazon or Audible or wherever books are sold.
Fantastic. Dr. Aaron Hartman, there's a lot here. The show notes are going to be very important to my listeners, but thank you so much for being here and just tying a bow around this because I know there's going to be more questions, but if there are questions, I'll send them your way.
Sounds good. Thanks. I really appreciate it. It's fun.
Thank you. Before you go, thank you for being here. If you want to go a little deeper, make sure you check out the show notes for this episode. That's where I link anything we mentioned, resources, partners, or tools I actually use and trust. And if you're not already on the Asking for a Friend community newsletter, that's where I share practical midlife tips, favorite finds, recipes, and the things that don't always make it onto the podcast or Instagram. You'll find the link to join in the show notes. Take care, and I'll see you next week.